everyone, my name is Dr. Sadiya Khan, and I'm here at AHA Epi Lifestyle 2026 with Dr. Donna Lloyd-Jones, who was a member of the writing group for the 2026 Multisociety Dyslipidemia Guidelines. We're really excited to have a conversation today about how PREVENT was used in the Dyslipidemia Guideline. Thanks, Dawn, for joining me.
Sadiya, it's great to be here with you, and it's great to be hosting people here in Boston, my new hometown.
Well, let's get started. If we think about risk prediction more broadly, this was not the first time risk was used in a guideline. Tell us why risk has been used in cardiovascular disease prevention, and then we can talk about why PREVENT.
Sure. So you're absolutely right. Really since ATP3, risk prediction has been really a cornerstone of primary prevention. That is to say, really since 1996 in the Bethesda conference, this concept that we want to match the intensity of our prevention efforts to the absolute risk of the patient really is kind of at the core of all of this. And, conceptually that makes sense. That has a lot of face validity. But I think as time has gone on from 2003 with ATP3 to the 2013 guidelines where the pooled cohort equations were introduced to 2018, and now with these exciting new guidelines in 2026, it's become more and more really the bedrock of how we do this. And to be honest, I think the rationale for doing it has also evolved. What that means is that I think we now have plenty of evidence from randomized controlled trials, as well as observational data, that can help us gauge the absolute risk of the patient, the expected benefit in terms of how many heart attacks and strokes we can prevent, but also the potential for harm. And the most common significant potential harm is that we might induce elevations in blood glucose that could lead to the diagnosis of diabetes. So on an absolute scale, we can actually match up the potential for benefit, the potential for harm, and make smarter decisions about which patients really will benefit from these medications.
So if I'm trying to counsel someone about their potential benefit from a statin medication, what I'm really trying to gauge is it worth it to take this medicine, and how much potential harm could there be?
Right. I think in secondary prevention, it's easy, right? They have the disease. Of course, they should be treated because they're at super high risk for having it again. In primary prevention, I think it's more nuanced. And we know that the benefit is going to be much more likely to accrue to those people who are at high predicted risk because of their total package of risk factors that put them at that high predicted risk. As that predicted risk gets lower, the margin gets smaller. And that's where I think these equations can really help us start that conversation, and we'll talk, I know, in a second about the thresholds that were selected for thinking about starting statin medications for dyslipidemia and for risk reduction. But, I think that general concept is high-risk people are going to benefit a lot. Intermediate risk people are going to benefit some, and we want to be as smart as possible about selecting them. Low-risk people are perhaps not likely to benefit at all, and maybe we're more likely to induce new diabetes, if you're worried about that, than we are actually to prevent a heart attack or stroke. So we shouldn't be treating in that zone.
So you're saying be smart about predicting who should get treatment or who may benefit from treatment. So why was PREVENT picked for the dyslipidemia guideline?
Sure. Well, I'm sitting next to the person who had more to do with the development of the PREVENT equations than really anybody. But I think we recognize that with the pooled cohort equations, which were really state-of-the-art for their time in 2013, it was time for an update. It was time for an upgrade. The pooled cohort equations, as they were studied, seemed to be overestimating risk in a number of populations, particularly, at and above the decision threshold of 7.5% that was identified by the guidelines from the randomized controlled trial data. But that overestimation was somewhat problematic, and those were not as contemporary derivation samples and populations. And so I think there was a real opportunity to achieve a number of things with PREVENT. One, expand the outcome, not just ASCVD, but also think about heart failure, which is really the epidemic that's emerging now more and more. So we need to be able to predict that. We have therapies that can prevent heart failure, in addition to therapies that can prevent ASCVD. But also, I think the growing recognition that newer variables, including BMI, including some of the other things related to chronic kidney disease, could inform risk prediction. And in that setting, it was time to think about those commonly measured new input variables that could help us refine risk prediction and do that in a much more contemporary sample relevant to the current event rates that we're seeing in the population. So it was pretty easy, I think, for the guideline panel to select PREVENT as the risk prediction platform.
And that was our hope when we created the PREVENT equations, but it's great to see the guideline committee endorse that. But there was an additional task that they had to do that we didn't have to do, which was pick the threshold. So how did you get to the 3%, the 5%, the 10% numbers that are being used for the categories?
Yeah, it's a great question. And I think often there's some confusion about, well, why this decision threshold for consideration of statin therapy. But the truth is, this is nothing new, right? And one of the ways I like to contextualize this for clinicians is, I think a lot of people don't really ask themselves, well, why do we use a CHA2DS2-VASc score of 2 to choose people who need oral anticoagulation therapy for atrial fibrillation? Well, the rationale for that is exactly the same as the rationale that we used in the hypertension guidelines in 2025 and in the dyslipidemia guidelines here in 2026. And that is, again, lining up potential for benefit against potential for harm. So in that CHA2DS2-VASc AFib example, we know that the risk of bleeding with an oral anticoagulant is about 1% to 2% per year. The benefit we see that comes in from these medications starts at about 2% or higher risk of embolic stroke per year from being in atrial fibrillation. And so that 2% threshold per year of bleeding versus benefit really sort of cones you right in. And so a CHA2DS2-VASc score of around 2 is actually associated with an event rate of 2% per year. So if your CHA2DS2-VASc score is 2 or higher, we're more likely to prevent a stroke than we are to cause bleeding. Same exact rationale applies here. What we see from randomized controlled trials is that actually at a 10-year risk of 3% or higher, we're more likely to prevent a heart attack or stroke with statin therapy than we are to actually cause new onset diabetes. Again, if you're worried about that, they are not equal in terms of the severity of the outcome, but that's the most common significant outcome from statin medications. And so that 3% inflection point is where the potential for harm and the potential for benefit cross. And above there, while the margin is small, above there we start to see net benefit. And as you get further and further above that 3% threshold, the margin gets bigger and bigger in terms of net benefit.
So 3% is a little bit like the sweet spot, but there's also this recognition at 5% and at 10%. And what do you do differently at those points?
Yeah. So looking at all the data from the randomized controlled trials, what we said was that clearly with a 10% predicted risk using PREVENT, that's a high-risk scenario. And it's essentially equivalent to secondary prevention event rates. So we know from trials that at an event rate that high, there's clear net benefit. So that's a 1A recommendation. Plenty of controlled clinical trials showing us that there's benefit there. So everybody should be recommended in that group. We called the new intermediate risk group 5 to 10%. And there, while the margin of benefit is getting a little bit smaller, there's still clear net benefit. So again, this is a 1A recommendation for that group. But we also recognize, for example, that there will be people within that group, who, for example, don't have coronary calcium. Their coronary calcium score is 0. So if you choose to measure that and you find a coronary calcium score of 0, it may be reasonable to defer therapy. You may want to look again in a few years, but it may be reasonable to defer therapy, work on lifestyle, other approaches to controlling lipid-associated risk. And then moving down at the 3 to 5%, we now call borderline risk. Again, there the margin is quite small. And that's where I think you really want to have a conversation with the patient about their personal perspective on risk and how aggressive they want to be to reduce that. But again, a coronary calcium score could be really useful in someone in that range if you think they're, potentially at risk and you'd like to get them on a statin. Show them the image, right? If the CAC score is 0, they're actually at lower risk than you thought. If their CAC score is elevated, especially over 100, they're at significantly higher risk than you thought, and we really should be looking to reduce that lipid-associated risk.
So last question, we've talked about the 10-year risk thresholds, less than 3%, 3 to 4.9%, 5 to 9.9, and greater than 10. What about 30-year? How did that get integrated?
So one of the nice features of the PREVENT equations is that they not only provide a 10% predicted risk, they also provide a 30% predicted risk for individuals in the range of 30 to 59 years. And I think increasingly, we understand that especially for younger patients, while their 10-year risk may be low simply because they're young, they are accruing vascular damage because of exposure to these chronic risk factors over the long term, even if those risk factors don't exceed clinical thresholds for diagnosis of hypertension or diabetes or dyslipidemia. And so we want to reflect that longer-term exposure to those risk factors, and that's what I think a 30-year or a lifetime risk estimate can do for us. We also know that the earlier we treat, the bigger the benefit is going to be. And I think one of the real themes in this guideline was recognizing risk earlier, and even potentially treating earlier so that we get that long-term benefit and not just focusing on the 10-year risk. That's been, I think, a valid criticism of prior guidelines. And we really tried to incorporate all the information we could. And that's where the 30-year risk estimate comes in. So as you pointed out, start to consider statins with a 2A recommendation in 3 to 4.9%, but 1A recommendations at 5% and above. Well, what about that younger person with a 10-year risk estimate that's less than 3% because they're young?
Or even as a young woman.
Or even as a young woman, absolutely. But they actually have, again, metabolic syndrome or a constellation of risk factors that you're worried about. I think incorporating either they also have a high LDL or a 30-year risk estimate over 10%, that would indicate a person who is on the fast track, maybe not in 10 years, but certainly in 20 or 30, where you might want to intervene sooner. And so that's a part of the conversation.
Yeah, and this follows really nicely the high blood pressure guideline as well that use the prevent CVD, and here we're focused on the prevent AS-CVD equations, but they all really seem to follow the same pattern. It's predict risk earlier, starting at age 30, get a 10-year and 30-year risk estimate, and start detecting risk earlier and treating risk earlier.
I think that's right. And if nothing else, that 30-year risk estimate can be used, I think, to motivate more lifestyle intervention and more aggressive and perhaps successful lifestyle motivation. And so, I think clinicians do need to get more comfortable having these conversations with their patients. Start with this quantitative risk estimate, but that's just the start. Then think about those personalization factors. Do they have a strong family history? Do they have a background of some chronic inflammatory condition? Other things that are mentioned in the risk enhancers in this guideline. And then, if the clinician's still uncertain, or especially if the patient's uncertain or perhaps resistant to taking therapy, use the tiebreaker test that is definitive. Do they have atherosclerosis? Do they not? And how much if they do? And, I think that really gets us to much smarter decisions and better places.
Absolutely. This is really exciting, and the advances in the 2026 guideline give us a lot of opportunity to modify the future trajectory of heart disease. Thank you so much for joining me, and excited to see the improvement in cardiovascular disease prevention that will come from this.